vascular. No, we don't need him at this moment.
تمام حاضر.
And now you need to have the slide show. Slide show. Okay, now you have my full screen available.
لا يا دكتور.
You don't have it? Okay.
مش فول سكرين.
Okay.
ايوه تمام يا دكتور.
You can see it now?
ايوه يا دكتور.
Okay. Okay, great.
لو هبتدي يا دكتور احنا 65 دلوقتي.
نبدأ. Okay, Bismillah. We are going to continue our sessions about some MCQs, case-based discussions, new index of suspicion, and visual diagnosis based on new reviews plus. And before we start our regular MCQs, I have some like an appetizer question for everybody. I need everybody to share with us. It is very simple, but the differential diagnosis is very wide. And as we mentioned hundreds of times, the goal is smart clinical thinking, smart clinical approach. And although many times we present rare cases, but through our approach to these rare cases, we go through important differential diagnosis. We know how to think smartly and how to reach our diagnosis and how to exclude the diagnoses one by one to reach the final diagnosis. So, question, what is your differential diagnosis for a term newborn infant who has two main major problems, a rash on the face and seizures? Rash on the face and seizures. I like you to be more organized and go in a systematic way, meaning you mention the broad item of the etiology and then the underlying causes. And after that, we'll have our discussions. Yeah. So I see. Yeah. None of you did the way I like. I see
Infection?
HSP, torch, traumatic, stage Weber infection. No. This is not the way to reach the diagnosis. You have to go by broad items and then underlying causes. Meaning, if you say HSV, you might have this under viral infection. If you say torch, you might put this under infection in the congenital infections. Traumatic birth injuries, and then you mention what type of trauma that can cause rash and seizures. Sturge-Weber is under neurocutaneous syndromes. You see what I mean? Okay. So if we go by infection, what type of infections that can cause a rash on the face and seizures? Okay. Infections. Birth trauma. Viral, bacterial, yes, this is good. If you say infections, you say congenital or acquired, viral, bacterial, fungal, or even protozoal infection. This is good. If we go infection, congenital, we have the torch, yes, but we have some important congenital infections that are on top of the list. Like what? Like CMV, great. So in CMV, what is the rash and why this baby is having convulsions? Yeah, I see congenital syphilis, which is good choice. Yeah, HSV, varicella, yes, correct. Congenital varicella. Meningococcemia is not under the virus. It is bacterial. It's very rare in newborn, but it can happen. Yes, it goes under bacteria. Syphilis under congenital infections, torches, and congenital syphilis. And we discussed congenital syphilis many times before. So important infections, congenital, comes on top of the list is the torches, and then acquired, viral, like HSV, herpes. You have to have herpes in all or your differential diagnosis when you think of non-specific generalized sepsis. And the type of rash in congenital infections in torches, it's the blueberry muffin, In syphilis, it's not blueberry muffin, it's like maculopapular erythematous rash, and sometimes there is some desquamation. Also, congenital infections could be as we said, bacterial like syphilis, fungal. There is an important item which is missed by most of us, which is the congenital candidiasis. With congenital candidiasis, you have two types, either the cutaneous type, which is localized only to the skin, and there is the systemic type, which is more serious. It affects every and each organ in the body. Definitely, it presents with a rash anywhere, including the face, and also it can affect the CNS, the heart, the kidney, the lungs. So, infection, congenital, acquired, viral, bacterial, fungal, or protozoal like in toxoplasmosis. Okay? Other important bacterial infections which we might see in the newborn and is the baby might have seizures if it's complicated, like what? What are the important infections that could show on the face and could be complicated with meningitis or brain abscess or cavernous sinus thrombosis because it's in the dangerous area of the face and causes seizures, like what?
وثانيا ناتورا.
Listeria is a good choice. Staph, especially the staphylococcal scalded skin syndrome. Also, strep if you have like impetigo or cellulitis. Each one of them could be complicated with intracranial infections and seizures. Great. So we covered most of the important infections. Then what else? What is the next item? The broad item. Neurocutaneous syndromes. What are the important neurocutaneous syndromes you think can cause a rash on the face? And when I say on the face, I didn't say only to the face. It could present with rash in the whole body, including the face. But if the question is face and seizures. Sturge-Weber syndrome. What do we have in Sturge-Weber syndrome? We have we have port wine stain in the distribution of the trigeminal nerve. We have eye involvement, mostly glaucoma, and we have intracranial leptomeningeal problems that can cause seizures. And then comes after Sturge-Weber, what other syndromes that can cause seizures and face rash? The TS, yes, the TS can present with hypopigmentation anywhere, including the face, intracranial cardiac problems that might lead to seizures. TS, tuberous sclerosis. What else? Neurocutaneous syndromes important in the differential diagnosis of Sturge-Weber. And I think we discussed on one MCQ at some point for a baby who was the discussion was between Sturge-Weber and this syndrome, which is face or faces, PHACES. It presents with hemangioma on the face and intracranial problems, cardiac problems, eye problems. It's called faces syndrome. And also I see incontinentia, yes, incontinentia pigmentile, which occurs in girls because it's X-linked dominant, very, very rare in boys. Rash, which is very specific depending on the stage of the disease and the age of the baby. It affects the brain. It will lead later on to developmental delay because it's neurocutaneous. It affects all derivatives of the ectoderm, which includes the teeth, the hair, and that's it. So important neurocutaneous syndromes, the Sturge-Weber, faces, incontinentia, and there is another less important, something called nevi. Some type of the nevi, of the nevus is associated with intracranial issues, seizures, and skin manifestations in the form of nevus. Okay, now we are done with the neurocutaneous syndromes. What other major item under which we can find some problems? Infections, neurocutaneous syndromes, metabolic. What is the metabolic disease that can present with rash and seizures? I don't have anything in my mind now. Here's some baby saying hematology. Yes, hematology means blood disorder, like congenital leukemia or the other. There is another important syndrome which also affects. It could be localized or generalized, and if it's generalized, it affects the brain and the skin. It is Langerhans, yes, Langerhans cell disease, which is different types. So hematological. Okay, what else under hematological? Yes, any purpura could present with intracranial bleed. Any hypercoagulable states, and the most important one of them, yes, we see the DIC, we see purpura fulminans. Purpura fulminans due to protein C and protein S deficiency. You can have hypercoagulable state, intracranial thrombosis, and strokes. Okay, so infections, neurocutaneous syndromes, hematological disorders, which might be congenital or acquired due to either bleeding tendency or hypercoagulable states. And then, yes, congenital lupus, which comes under immune disorders. Congenital lupus can present also with rash, characteristic rash on the face, with with cardiac problems, with intracranial problems, and seizures. Hemorrhagic disease of the newborn due to vitamin K deficiency can present with what is the skin manifestation of vitamin K deficiency? Media to everyone. What is media? Is it AI or what is media? Hemorrhagic disease of the newborn. How can hemorrhagic disease of the newborn cause rash on the face and seizures? It can cause intracranial hemorrhage, yes, but rash, I don't know about that. Ecchymosis, maybe, but it's mostly intracranial bleed or GI bleed. But theoretically, it can cause ecchymosis, yes. Clotting factor deficiency, how can they present with a rash? There is no known rash. It's bleeding tendency from anywhere, but I don't think they cause a rash. Okay, so let us keep going. So as we thought, infections, neonatal herpes is extremely important. Varicella, we have either acquired varicella, neonatal varicella, or congenital varicella syndrome. Also, we have the torches, bacterial with meningitis, listeria, staph, strep, in the form of impetigo or cellulitis, complicated with intracranial infection. Fungal infection like congenital systemic candidiasis, neurocutaneous syndrome, Sturge-Weber, TS, Faces syndrome. The Faces syndrome, we have posterior fossa malformation for P, hemangioma for H, usually in the face area, A, arterial, anomalies in intracranial, C, heart, E, I, and S. Some people say face, others call it faces with sternal abnormalities and cleft or ectopia cords. Yes, this is the nevus I told you about. It's called epidermal nevus syndrome. It is very rare, but it can happen, and it can cause seizures and face rash. IP, as we mentioned, and the rash, there is 4 stages of rashes depending on the age of the baby. And the one that we can see in the newborn is blistering. And then after that, it will turn out into work-like rash, in addition to the female sex and no male siblings and a history of maternal abortion and intrauterine fetal death. Autoimmune, the lupus, if the mom has lupus or antibodies. Vascular and structure, we talked about intracranial hemorrhage with a rash, and we talked about stroke with a rash, like in thrombocytopenias with purpura, in DIC with ecchymosis and purpura, with purpura fulminans with a characteristic gangrene-like lesion. Okay, when we talk about the morphology, we can classify it depending on the lesion. It could be papular, maculopapular, vesicular, pustular, purpuric, ecchymotic, nevus. It could be any type of the known skin rashes. Vesicular and blistering, like in HSV, and in the varicella, and erythematous or maculopapular or annular, like in IP or in neonatal lupus. It could be cellulitis, abscess, erythema only, like in sepsis. Blueberry muffin, like in congenital infection. Could be capillary malformation, which is the port wine stain, Sturge-Weber. Or it could be hypopigmentation, like in TS. It could be petechiae and hemorrhages, as we mentioned. Oh, some of the pictures, which will help you. This is a newborn infant, and this is the classical face rash of what? Classical face rash of congenital. No. Congenital. Yeah, it looks like impetigo. It looks like CMV. It looks like But it is lupus. Yes, Dr. Mustafa. Yes. Yes, it is congenital lupus. And this is the port wine stain. This is a picture from the case that we discussed before, and we were confused between it's Sturge-Weber and this is port wine stain, or it is capillary hemangioma and this is Faces syndrome. And after consulting the dermatologist and the geneticist, it was proved to be a Sturge-Weber. And this is the same port wine stain, Sturge-Weber, in the distribution of the trigeminal nerve. And both Faces and Sturge-Weber can be associated with congenital glaucoma. This is easy. This is easy. What is this? 4S, yes, S. Yeah, this is herpes, and this is congenital candidiasis. It can be macular, papular, maculopapular erythematous with peeling of the skin. And this is the congenital syphilis rash. And characteristically, it affects the palms and soles, but it can affect the body, the face. And this is another Sturge-Weber. Yes, this is the Faces syndrome, and this is the classical hemangioma on the face with the other criteria of the Face syndrome. This is IP incontinentia at some stage, because it depends on the stage, but it starts with bully and then it will change. The rash will change. This is varicella, and this is impetigo. And it is in the dangerous area of the face, so it can be complicated with intracranial infection, cavernous sinus thrombosis, brain abscess, meningitis, all can lead to seizures. This is the SSSS, and this is the another neonatal varicella. Neonatal varicella. Yes, this is the blueberry muffin, which can affect the whole body, including the face. The face, the blueberry muffin, it's in torches infection. Blueberry muffin. Oh, this is the purpurefulminants. Protein C and protein S deficiency. Hypercoagulable state starts with vascular clotting in the microvasculature of the skin, and then will turn up into a DIC. It's a very complicated. It could be, usually it's congenital, but it could be associated or precipitated by infections. And this is also I believe the port wine stain. Oh yes, this is the nevus I told you about. It could be on the face, could be associated with seizures. And this is some of the characteristics of some of the conditions. And I will send all this to you. Okay, questions before we go to the MCQs. Questions, comments, hosts and patients. Any questions? Oh, okay. One MCQ is a 14-day-old, 14-day. And we have to look at the keywords evaluated in the ER for abnormal movements in the last 5. No, this is not sorry. This is not the question. We discussed this before. I'm sorry. No, we'll go to 6. Yes, I'm sorry. This is a 27-week is being discharged home in the month of October of 30. No, this is not the one. This is immune disorder. I'm sorry. I have tons of questions, so sometimes I get confused. Yes, this is the one. 33 week and has craniosynostosis of the sagittal suture and a pectus deformity, chest deformity, craniosynostosis, pectus deformity, 33 weeker. The weight and length are at the 5th percentile. So this baby is intrauterine growth restriction and also SGA. And here comes the more important words, keywords. The mother has early loss of her permanent teeth. So there is teeth problem in the family. So we have positive family history affecting the teeth and joint pain and the joints. A 3-year-old sister has rickets. So 33 week craniosynostosis, chest deformity, SGA, intrauterine growth restriction, positive family history in the mother and in a sister, affecting the bone, the joints, the teeth, and the girl has rickets. Rickets. The infant is now 3 weeks of age and receiving full volume enteral feeding. So he's getting adequate feeds, fortified, which is in the form of fortified expressed human breast milk. So nutritionally, the baby is getting good amount of feeds, well fortified. It is fortified to 24 calories and then to 26 calories by day 12 of age. However, the infant growth is still poor. So intrauterine and extrauterine growth is poor. And then started to have new painful swelling of the left thigh, which proved to be a fracture of the femur. With displaced femur fracture at the level of mid shaft. Also, the bone shows hypomineralization. So, hypomineralization of the bone fracture, irregularities of multiple bones, meaning he had many previous fractures that started to heal irregularly. So, at this point, what is the broad spectrum we are talking about? And then Hala jumped to the diagnosis, hypophosphatasia. So you don't have any other differential diagnosis. You don't have any other differential diagnosis. If I am in your place, I will say this is an inherited. So inherited, most probably, it is related to some inborn error of metabolism. Disease that starts in utero, causes SGA and intrauterine growth restriction, affecting more than one family member, disease of bone mineralization, which like osteopenia or rickets or some sort of bone problem, fractures, poor growth, hypomineralization of bone. This is, so we are dealing with this kind of disease. Is this osteopenia of prematurity? I don't think you listen to me carefully. You do jump to a single diagnosis, and this is a wrong way of thinking. This is not the proper way of thinking. Think smart. At first you have to decide at what category this disease falls in. This is a hereditary or congenital problem. Number two, it's a problem of bone, teeth in the future, joints, hypomineralization of bone, affecting growth intrauterine and extrauterine. This is the next step. The third step, is it acquired or congenital? Acquired, like vitamin D deficiency in the baby or in the mother. Congenital, like osteogenesis imperfecta. And then at this point, you can start talking about hypophosphatasia. At this point, you can start talking about hypophosphatasia. If you jump to hypophosphatasia, this is a wrong way of thinking. What happens in real life, in practice, is that when we see such a case, every one of us will jump into a diagnosis and will try to prove that his diagnosis is the only correct diagnosis. And he will not think broadly, and he might miss a lot of other diseases. And he will not do the required labs. So, although our dear friend said hypophosphatasia from the get-go, which is correct, but I didn't like it because you didn't listen to me. Go systematic, go step by step. Don't jump into a specific diagnosis. Okay? We are dealing with an inherited disorder affecting bone, teeth, joints, growth, intrauterine and extrauterine. And this disease is hypophosphatasia. Question, if this is hypophosphatasia, what is the serum laboratory values most likely present in this infant? Is it the alkaline phosphatase is going to be high and the phosphorus is high, or alkaline phosphatase is high and the calcium is low? Alkaline phosphatase is low and the calcium is high, or alkaline phosphatase is low and the phosphorus is low. So most of you went between C and D. So C, low alkaline phosphatase. So the enzyme alkaline phosphatase is low and the calcium is high. And the second choice of you was low alkaline phosphatase and low phosphorus. So in hypophosphatemia, what happens? Everybody's in now. The more D's than C's, more D's than C's. So you think the phosphorus is low in the blood, and the alkaline phosphatase is low in the blood, or the phosphorus is high, which you don't have here, except with increased alkaline phosphatase. The correct answer is C. And the disease is hypophosphatasia. Okay? And this question is not to discuss a rare disease. It's going to discuss the smart clinical approach. And we are going to talk about a very important enzyme, which we order hundreds of times. But most of us don't know much about this enzyme. Okay? Which is the alkaline phosphatase. What happens in hypophosphatasia is that it's, of course, a genetic disease. There is mutation. And as I told you hundreds of times, in order to reach a diagnosis for many of our diseases, you have to have two important parameters. A very it's up to date genetics lab, and a very experienced and knowledgeable geneticist. And unfortunately, most of our NICUs don't have those, which makes me unhappy about the future. Because at some point, the more the medicine is advanced all over the world, the more the underdeveloped countries are going backwards, which is something bad. Okay, so there is loss of function because of mutation of the gene responsible for a non-specific alkaline tissue alkaline phosphatase. It lies on the chromosome number 1. And this disease has variable presentations. It could present in the perinatal period, it could present later in childhood or in adulthood. It could be mild, moderate, or severe, which makes the diagnosis difficult. And if this case was mild, you have to think of other problems like osteopenia of prematurity, like vitamin D deficiency, osteogenesis imperfecta, other malabsorption syndromes affecting the absorption of vitamin D, and so forth. The other important issue about the alkaline phosphatase is that it is very important for the metabolism of vitamin B6. That's why in those babies, they could develop seizures. And the seizure is not because of low calcium. The calcium is high. Is not because of the low phosphate. Phosphate is high. But because of vitamin B6 dependent seizures, because the metabolism of vitamin B6 is controlled by the alkaline phosphatase. This is one of its major functions. So what we have is low alkaline phosphatase, elevated serum, and urinary calcium and phosphorus. And the problem with the urinary high calcium and phosphorus is this baby might develop at some point nephrocalcinosis. So how many types of alkaline phosphatase you know about? How many isoenzyme you know about alkaline phosphatase? 1, 2, 3, 4, more. And then what are the important organs of the body that have this enzyme, alkaline phosphatase? انزيم مش موجود، كالسيوم عالي، مش لاقي انزيم يخليه يمسك في الفوسفور. ايه انا مش فاهم دي اجابه انه سؤال اللي انا قلته، انا مش فاهم. دكتور مصطفى says 2. Dr. Keira says liver. Muscle? Does alkaline phosphatase come from the muscle? Liver and placenta, yes. Liver and placenta, okay. 2 is not correct. It's more than 2. 4, yes. Okay, we'll proceed. So the critique, the infant in the vignette has clinical features and a family history consistent with hypophosphatasia. There is, why? Because there is family history of rickets, early tooth loss and joint pain in the family, craniosynostosis in the baby, chest and rib deformities in the baby, radiographic findings of diffuse hypomineralization, metaphyseal irregularities, which we see in rickets, a fracture, which we saw in the midshaft of the femur, poor growth intrauterine and extrauterine. Additional features could be hypotonia, bowing of the arms and legs, because this baby is like having rickets. Progressive chest deformities leading to respiratory problems, and vitamin B6 dependent seizures. Don't forget about this. Okay, when you have a baby with vitamin B6 dependent seizure, and this could be mild hypophosphatasia. So dig deeply, maybe it is mild hypophosphatasia. So it has another name, Rathbun disease. It's a rare genetic disorder, and it affects the non-specific tissue, non-specific alkaline phosphatase. It affects bone, liver, kidney, teeth. We have multiple enzymes, at least 4 of them. And the sources of the enzyme mostly from the liver and from the bone. So when you have a baby with high alkaline phosphatase, look for the liver and bone. When you have a baby with low alkaline phosphatase, look for the bone. Okay? And it could be, as I said, in the perinatal area, age, or later on, could be autosomal recessive in our babies, or the late onset could be autosomal recessive or dominant. And one of the diagnoses, the laboratory diagnosis of lab, is to look for the accumulation of the enzymatic substrates, because alkaline phosphatase works on the metabolism of B6. So if it is deficient, the substrates in the vitamin B6 metabolism will be high, which is inorganic pyrophosphate. This is one of the clues for the diagnosis. What is the function of the non-specific ALP? It causes hydrolysis of the PPI. So if it is deficient, the PPI will high. This will cause releasing phosphate, which becomes available for the formation of hydroxyapatite crystals in bone. So if it is deficient, the bone will be deficient, and the PPI will be elevated. So we have hypercalcemia, we have hyperphosphatemia, we have elevated PPI, we have low alkaline phosphatase. And we have increased secretion of calcium and phosphorus in urine, which is a bad sign. And this is how the relation between B6 metabolism and the alkaline phosphatase. I will not go into deep organic chemistry, but you should know that. And it could present with vitamin B6 dependent seizures. So it can have other problems in addition to the bone and teeth and joints, neurologic manifestations such as cognitive function, alteration in memory, and it can affect adults. So it could affect us. Memory, attention, regulation of emotions and behavior, and effects on sleep and anxiety. He is describing like 50% of our population. A high index of suspicion, yes, you should have a high index of suspicion when you have such presentations. And then here comes the genetics. Molecular analysis of the alkaline phosphatase gene is recommended to confirm the diagnosis. So this is the gold standard, because you have variable degrees of presentation, you have different ages of presentation, you have different modes of presentation. So the gold standard is molecular analysis of the gene, which needs a very, very up-to-date advanced genetics lab and very experienced, knowledgeable geneticists. Okay, another important issue is what is the differential diagnosis? And you should have started with this list, and then you exclude them one by one. This is the proper way of thinking. Nutritional deficiencies, of course, vitamin D, or if calcium and phosphorus are deficient in the formula in the preterm baby. Osteogenesis imperfecta, type 2, because we have hundreds of types of osteogenesis imperfecta now. And also this is based on genetics. Intestinal malabsorption and disorders of phosphate metabolism, like drugs. And we have a list of drugs that can affect the phosphate metabolism, as we are going to see in the table. Osteopenia of prematurity, which is an acquired disease, unlike what happens in this baby, although this baby was preterm. And the treatment is supportive, low calcium, and now they have a replacement of the enzyme. I don't know if it is available in our countries or not. Other remote differential diagnoses include achondroplasia, hypophosphatemia, osteomalacia due to vitamin D deficiency, rickets, and thanatophoric. Of course, rickets, this is in older babies. Thanatophoric dysplasia. Okay, and this is some example of the medications that could affect the metabolism of phosphate of alkaline phosphatase, causing differential diagnosis for hypophosphatasia. The most important one is the one that we use too much in the NICU, which is the steroids. Other drugs, we use them in older patients. And then comes vitamin D deficiency. On top of the list is vitamin B6. You could also have zinc deficiency, because zinc is important for the metabolism of the alkaline phosphatase only. And one of the indirect methods, if you don't have the luxury to detect the zinc deficiency by checking the zinc level, you can check the alkaline phosphatase level. It is an indirect lab for zinc deficiency. Okay? And then comes magnesium deficiency, vitamin C, vitamin B12. Other endocrine problems like hypothyroidism or hypoparathyroidism. And then severe anemia and others. There is something called milk alkali syndrome, but I don't think we use this in newborn. We have this in the newborn. Okay? Then I will jump to alkaline phosphatase. Yes, just to review, these are the laboratory findings in hypophosphatasia, which is low alkaline phosphatase. Hallmark is serum level of alkaline phosphatase activity below age. And in the newborn, the range is between 28 and 300, depending on what lab you are using and what units you are using. Measuring is a key step. The hallmark biochemical finding is reviewed and yes, so we are going to see this in maybe in the table. Hypercalcemia, hypercalcinuria, hyperphosphatemia, hyperphosphaturia, and nephrocalcinosis. Impaired mineralization, baby will look like rickets, severe rickets with fractures. And high PPI, as we mentioned, and the genetic testing to confirm the diagnosis. Of course, imaging studies are important to show signs of rickets. Yes, the enzyme replacement, the enzyme available now is called aspartate alpha. Aspartate alpha. And also, I think there is other advanced and genetically determined modes of treatment. There is another important item which is called transient hyperphosphatemia of infants. It is transient, and it returns back to normal. So if the baby is asymptomatic and for some reason you find low hypophosphatemia, and don't rush into the diagnosis of infantile or hereditary hypophosphatasia. Just keep an eye on this baby, do a careful workup, do careful imaging of the bones, and then if nothing is abnormal, this baby might have transient hyperphosphatemia of infancy. But I'm not asking you to miss hypophosphatasia. Just if the baby is asymptomatic and for some reason the alkaline phosphatase was low, just do everything you can do and then keep an eye on the baby because this baby might improve on its own. Then comes alkaline phosphatase. It removes phosphate group from nucleotides and proteins. And this enzyme works optimally at basic pH levels. So there is an optimal pH for alkaline phosphatase to work. It is found mostly in the bones and liver, but it could be in other tissues, as we are going to see. And we have different isoenzymes, at least 4 of them. It is present in the placenta, in the kidney, intestine, and leukocytes. I didn't see muscles for dear friend who mentioned muscles. So what makes alkaline phosphatase high and what makes alkaline phosphatase low? So it comes from the liver and bone. If there is hepatitis or obstructive biliary obstructive problem, it will go high. It is high also when there is high turnover of bone formation, like what happens in the preterm and in children. Usually the levels are higher than in adults, also following fractures. Okay, what makes it low? We mentioned it's mostly hypophosphatasia, transient hypophosphatemia, transient hypophosphatemia of infancy, and if the baby is on certain drugs, if there is like rickets or osteopenias. Okay, these are the main causes. So bone is one of the major sources of alkaline phosphatase. And these are the details of the organic chemistry. So low is typically additional evaluation of this infantile compound, including hypophosphatasia genetic condition. Yes, it includes other problems. It may be nutritional, as we mentioned, poor nutrition. It could be magnesium or zinc deficiency or even vitamin C deficiency. So all these are nutritional deficiencies that can affect alkaline phosphatase level, make it low, the protein, the magnesium, the zinc, vitamin C deficiency, in addition to the hypophosphatasia or transient hypophosphatemia of infancy. Okay, this is what does the alkaline phosphatase do and where it lies in the liver, bone, placenta, intestine, kidney, granulocytes, but not muscles. And it's mainly related to calcification of bone and metabolism of vitamin B6. And it requires magnesium and zinc and vitamin C to function for the metabolism. And this is on the cellular level in the liver. This is in the liver. And this is what happens if there is extrahepatic biliary obstruction, which we can happen in our babies if there is extrahepatic biliary atresia. And this is more sophisticated lab illustrations. And this is If you want to see the diseases that cause increased alkaline phosphatase in osteomalacia, this is in adults. In rickets, yeah, I think I mentioned the alkaline phosphatase will be low in rickets. Did I say that? If I say that, I was wrong. It is high. Bone growth, of course, this is normal. Fractures, following fractures, yes. In hyperparathyroidism, it might be whether primary or secondary. That's why this, although this disease is very rare, but it opened a lot of discussions about differential diagnosis and many, many other medical problems. Okay. Any questions, any comments before we go to the next MCQ? Okay. This is a very important question because we are dealing with very common issues in pregnancy and in the newborn baby. We have a term infant was delivered by urgency section because of fetal intolerance of labor. The baby was doing bad during labor. Bad means by monitoring the fetal heart rate, pattern and rhythm and the number of beats per minute, tachycardia or bradycardia. So they had to do urgency section. Important key point is mom used ibuprofen during the whole course of pregnancy. So from the get-go, from day one, till she delivered, she received ibuprofen for headaches. Baby comes without any respiratory effort at all, required intubation in the OR and positive pressure ventilation. Apgars were 2, 3, and 5, low, low, low. And the baby blood pressure was low, systolic 35, diastolic 28. For a term baby, this is very low. Heart rate 160. And then was given a bolus of normal saline. And they did an X-ray. They found patchy infiltrates on the X-ray. Then they did echo, which revealed the following: dilated and hypertrophic right ventricle, flattened interventricular septum, low normal left ventricular chamber size with mild to moderately depressed function of the left ventricle, without evidence of abductus, with patent ductus. So we have a term baby, C-section for fetal intolerance of labor. Mom had ibuprofen throughout pregnancy. Baby came limp, doing nothing, low, Apgar, intubated, mechanically ventilated, X-ray, some patchy infiltrates, hypotension, the baby was shocky. And as I told you, if the blood pressure is low, the shock is in advanced stage. If you think your baby is shocky, don't wait for the blood pressure to drop. Otherwise, you will be dealing with a late disease. Was given normal saline bolus, and then echo. All these are keywords. Dilated and hypertrophic right ventricle, flattened interventricular septum, low normal left ventricular chamber size and function is mildly to moderately depressed, and no evidence of patent ductus. So I think everybody knows what we are dealing with. So, however, the differential diagnosis at the time of delivery, and if you didn't take good history from the mother, still includes all types of neonatal depression. This baby was depressed at birth, did not required stat C-section for fetal depression and fetal intolerance of labor, and then had very low Apgars, required intubation immediately in the OR and positive pressure ventilation. So it could be cardiac, could be respiratory, it could be CNS depression, okay? It could be many things. And but the key points in the history of ibuprofen will make you try to exclude some of or most of these differential diagnoses. And the hypotension and the shock in the baby requiring normal saline bolus and the echocardiographic findings. These all are key words. So I see here premature duct closure secondary to ibuprofen use, which is an NSAIDs during pregnancy. Okay. And then comes secondary to premature closure, there is PPHN, which can explain all these echocardiographic findings. Left hypoplastic heart syndrome, ductus dependent. Left, my dear friend, this baby had echo. And these are the echo findings. And then after you see all these echo findings, you think this is hypoplastic left heart syndrome, which is ductal dependent critical congenital heart disease? No, no, sir. This is not left hypoplastic heart syndrome because we did echo already. So premature ductal closure, and it seems that duct closed very, very early in pregnancy. And this is important because mom was using ibuprofen for a long time. And then PPHN, and that's why this baby is very distressed, depressed, and really sick. Okay, after giving a normal saline bolus, which is 20, which is high, usually we give between 10 and 15, but they give 20 because the baby was very shocking. What are you going to do? What medications you think is correct? Are you going to give dopamine? So in order to say yes or no, you should know why. And why it will be based on what is the function of the dopamine. Are you going to give vasopressin, antidiuretic hormone? Are you going to give prostaglandin E1? Or are you going to give epinephrine? And you should know what does every and each one of those do, mechanism of action, and why it should be used as the first drug to improve this baby, because you can give one of them initially and then you can follow with the others. And each one of them has a role in this baby. But with this scenario in the vignette, you have to choose which comes first and then which comes after that. So I see prostaglandin E1, prostaglandin prostin. So for those who choose prostaglandin E1, why? How is prostaglandin going to help this baby? Relieve right ventricular pressure. How? Relax pulmonary vascular resistance causing. Okay. And then some people started to choose D, epinephrine. So why epinephrine? Because this could be a regular scenario that you could see in your NICU anytime. And tons of our pregnant women take a lot of medications, which they don't know how bad it is. And ibuprofen is one of the very common drugs used in our country. So ibuprofen is the key of this story. And so why adrenaline? To increase systemic resistance. This baby has evidence of left ventricular dysfunction and evidence of PPHN, evidence of ductus closure, and you want to increase systemic vascular resistance. So you give adrenaline to increase systemic vascular resistance. So you are going to make this baby more shocky, and you will make this baby go into like evident heart failure. This is not our goal. Okay. If you are going to give adrenaline, why? As the pulmonary hypertension phenotype 3, there is a left ventricular dysfunction on a low dose to give inotropic support without increasing. Yes, sir. Hala. Yes, this is a very good answer. Okay. Prostaglandin, vasopressin. Why vasopressin? What's vasopressin is going to do? And you said, no. The answer, prostaglandin followed by vasopressin, is not the answer. You are trying to trick us. You are cheating, my friend. We need only one medicine. So don't say so after. No, sir. Just pick up one. Some of the dear friends went for epinephrine, which is a good choice. And I saw a very good explanation for giving epinephrine. Why prostaglandin? Why vasopressin? Why dopamine? Dopamine to treat shock. Yes, this is good option. But is it a good option at this time? Prostaglandin, it opens the ductus. No one mentioned that. No one mentioned that prostaglandin opens the ductus. But does it open a ductus that have been closed for weeks and weeks and now it's anatomically closed? Here comes the trick. This mother was on ibuprofen for weeks and weeks and weeks, all through pregnancy. So this ductus is anatomically closed. Can you open a ductus anatomically closed with a prostaglandin? The answer is no. Okay, so the correct answer is D, and we're going to see why. Premature closure of the ductus causes volume overload on the fetal pulmonary circulation. Okay, the pulmonary circulation at birth is not ready to receive a good amount of blood from the right ventricle, still transitioning between the fetal life and postnatal life. So if we If you close the ductus that early in utero, you are taking a lot of blood to the lungs, who should not receive this amount of blood at this stage of development and after birth. This is why this baby developed PPHN. Okay, ductal closure in this neonate with premature ductal closure, restoring that. So your job now is to restore cardiac contractility. You cannot open these ducts at all. It's too late. So what you can work on is the heart. And the cause of hypotension and shock, it is the heart. So you have to give something that works on the heart, improve contractility of the heart. And this is the first step in the management. That is why we had to decided to use epinephrine. And epinephrine has 2 doses, and based on the doses, it has 2 functions. Has low dose and high dose, the same with dopamine. So epinephrine is used in this setting because it is a alpha beta agonist that augments cardiac function. Prolonged persistent elevation of the right ventricular systolic pressure may contribute to left ventricular dysfunction in this neonate because of premature ductal closure. The critique: premature closure of the ductus with resultant pulmonary hypertension. This is the case. Diagnosis is supported by the echocardiographic findings, and the ductus closed prematurity because of the ibuprofen, which was given for a long time and caused anatomical closures. That's why we didn't give prostaglandin first or at all. Okay, and then we know what happens in utero. We know the transition during birth, the normal physiologic. So this baby had a pulmonary volume overload leading to pulmonary vascular bed remodeling, PPHN, and then these echocardiographic findings, which show that the pressure was reflected on the right side of the heart and then reflected on the function of the left side of the heart. That's why we decided to give epinephrine. Epinephrine is a potent beta-1 agonist with inotropic and chronotropic effects, augmenting ventricular function, which is the main problem with this baby, with minimal vasoconstriction. This is important, with minimal vasoconstriction. Where is the part about the doses? Doses. There is some important issue about the dose of epinephrine. Based on the dose, you will expect 2 different functions. Oh yes, okay. At the vasodilator beta-2 agonist effect of epinephrine decreases peripheral vascular resistance and promotes pulmonary blood flow. At higher doses, alpha agonist effects predominate with vasoconstriction, which we don't need now at this point. For the unit in the vignette, treatment with epinephrine is likely to improve systemic blood pressure. And then comes the vasopressin, which is mostly a vasodilator. And I don't think we need it in this condition. If we give it in this baby, there will be a rapid clinical decompensation, including post-capillary pulmonary hypertension. It will make the condition worse because it increases systemic vascular resistance. It will make the condition worse by activating V1 vascular receptors, modulation of adenosine triphosphate sensitive potassium channel, modulation of nitric oxide, and potentiation of adrenergic and other vasopressors. So it's not a drug of choice at all. Okay. It is important to ensure adequate left ventricular contractility and normal function before you go to the dopamine, to the vasopressin. So it might be given later when you improve the heart contractility. So once this happens, you can give vasopressin. Dopamine, also it can be given in 2 doses, low dose, intermediate dose, high dose, and it has a renal dose when it's given in low, and then it has a vasopressor dose when it's given high. It's a non-specific vasoconstrictor directly stimulates alpha, beta, and peripheral dopaminergic receptors in a dose-dependent manner. Same with adrenaline, with different receptors. A potent vasoconstrictor because it also releases endogenous norepinephrine. Dopamine increases peripheral vascular resistance, the same problem. We had to see with vasopressin. Prostaglandin E1 is not beneficial because it's anatomically closed ductus. And then I'm going to stop at this point for the MCQs. And then any questions, any comments, suggestions? Now you see my screen again. Okay, you see my screen again. I will try to give you. I will try not to exceed the maximum of 2 hours.
لو
Of
فول سكرين
okay. It is. What about norepinephrine? There was no norepinephrine in the question. There was no norepinephrine in the question. Vasopressin is a vasodilator. I think I mentioned this. Vasopressin is a vasodilator. It causes dilatation also of the, okay? Okay. So a case. This case is important also because it will take us to a very important item, which is the malformation of the brain. Malformation of the brain. You should be familiar with the development of the brain in utero and what are the major malformations that could affect the brain and the ventricular cavities and ventricles and the ventricles, okay, on the ventricles. So we have a boy, mom is healthy, 23-year-old, gravida 1 para 0. At the gestational age of 21 weeks, they did sonography, ultrasound, and they were suspecting lobar holoprosencephaly with a genesis of corpus callosum. What is the holoprosencephaly? I need immediate answer before you go to the AI. In cardiogenic shock, we used dobutamine. Dobutamine was not in one of the choices. Mild line brain defect, midline brain defect, meaning yes, it's partial or complete failure of division of the two hemispheres. It's called holoprosencephaly, and it is three types, either lobar, alobar, and segmental, as we are going to see. So at this age, ultrasound was not very sure of the diagnosis, but they were suspecting lobar holoprosencephaly, meaning some dilatation in the ventricular system. They thought the two hemispheres did not divide well, and also suspected corpus callosum agenis, which is corpus callosum is a midline structure. So it could be associated an association with holoprosencephaly. It could be an anomaly on its own. And then at 30 weeks, they thought of something else. Open lip schizencephaly. They keep going back and forth between diagnoses. So initially thought of lobar holoprosencephaly, and then now at 30 weeks thinking of open lip schizencephaly. What does open schizencephaly mean? Immediate answer, no AI. Cleft, yes, correct. There is a cleft in the brain with different sizes, and it goes as deep as different degrees in the brain, and is filled with CSF. So moved from holoprosencephaly, lobar, to another type of schizencephaly, open lip, and then at 34 weeks, and found another. Now they are getting more and more close to the diagnosis, and now they have progressive enlargement of bilateral fetal cerebral ventricles. Okay, if you have a baby with progressive enlargement of the bilateral fetal cerebral ventricles, what is your diagnosis? And then what is the differential? What is the differential? The parents refused to do MRI at this point and refused genetic testing. You see, in every and each problem, you will find genetics. And if you don't have a good genetics lab and specialists, you are not moving anywhere, unfortunately. Storch, what does STORCH in storch inf? What does this mean? You think of you think torch infection. Okay, but before you think of torch, you think of hydrocephalus. And then we can look for what is the cause of hydrocephalus, which could be torch infection. YA. You are testing my English. What does YA mean? What does YA mean? It means yes. Yeah, yes. In American language, yeah means yes. Okay, yes. I'm okay now. Hydrocephalus, yes, syndrome. Miller-Dicker syndrome, septo-optic dysplasia, or Smith-Lemley syndrome. It could be. What else? You could have hydrocephalus. You could have hydrocephaly, or enlargement of the ventricles, which could also subside during and at the end of pregnancy, it will go away. So hydrocephalus, hydrocephaly. What else? We mentioned two already the holoprosencephaly, we mentioned that. We mentioned open lip encephaly, which is a possibility also. Okay, let's go and try to discuss some important problems affecting the development of the brain and causing brain malformation. So, okay. This infant was delivered at 41 weeks. And because there was thick meconium at the time of delivery, the birth weight was 2,660 grams, only 2%. The second percentile. Length was at the third percentile, 48. I don't know these percentiles are correct. 3 centimeter head circumference, 35, which is 35 percentile. The head circumference was appropriate for a 41 week. So the head was not large. This is important. Never mind about the length and weight. He transitioned Apgar scores 8 and 8. Physical exam. There was wide open anterior fontanelle, wide open posterior fontanelle, sutural splaying. The sutures were separated. So there was something wrong intracranially, maybe increased intracranial pressure, causing these signs. These also are. So the head was relatively large, because when you say the weight is low and the length is low, but the head is appropriate, it is relatively large head. So don't miss that. And no respiratory problem, good upguards, widely open fontanelles and separated sutures, but they were not bulging. There was no strabismus or sunsetting eyes, which are signs of hydrocephalus with increased intracranial pressure. Usually the fontanelles are bulging, you have strabismus and sunsetting appearance of the eyes. There was nothing of those. And then they did transillumination. And I believe transillumination is very good test. And can you give me 2 more examples when we can use transillumination and is very helpful? You use it in at the bedside. It's very helpful in 2 conditions. Pneumothorax, hydrocele, yes, thank you. There was no facial symmetric dysmorphism. So this baby was not symptomatic. There was no neurocutaneous stigmata. This was not a neurocutaneous syndrome, most probably, because it could be part of a syndrome. This is very common. The rest of physical exam was non-contributory. He didn't have any signs of lethargy. There was no encephalopathy, excess irritability, seizures, abnormality of tone or posture, high-pitched cry or moan. So this baby was not encephalopathic, was not more syndromic. Most probably the intracranial pressure was not high, most probably, clinically. And the head was relatively large for size, not for age, for size. Okay? This is the transillumination. What do you see here? Is this normal or abnormal? When you throw light through the skull of the baby, what is the normal? What's the abnormal? Is this normal? That light is everywhere, both sides, right and left. Yes, it is not normal. And this is whatever is we see here is either fluid, most probably it's fluid, which is CSF, most probably. So it is fluid CSF, most probably. So this is an abnormal finding. So if you see this picture, what is the first diagnosis on top of the list that we mentioned that could be the cause? Something which we didn't mention, I didn't mention on purpose. But now, after trans-illumination, what do you think this baby had on top of the list? Hydrocephalus? Bilateral, you mean? Bilateral hydrocephalus? Bilateral ventriculomegaly? Hydrocephalus, yes. Yes, it could be bilateral ventriculomegaly or hydrocephalus. But there is something more than uh, you actually see, you don't see a lot of tissue. You see, this is, I will show you, this is the scalp, and then most probably this is the bone, and then everything is red now. Yes. So do you think there is a lot of brain tissue here? So what comes before hydrocephaly or ventriculomegaly? Ventriculomegaly, hydrocephaly, hydrocephalus. What do you think? Cleft, schizencephaly. There is something called hydranencephaly. Hydranencephaly. So this is their differential. Severe hydrocephalus, yes, you mentioned that. Hydranencephaly, you didn't mention that. And lobar holoprosencephaly, we talked about that. Large open lips schizencephaly cleft, you mentioned that. Large porencephalic cyst, nobody talked about this. This is the main pathological and anatomical differential diagnosis. Could be syndromic, non-syndromic. Okay. Positive trans illumination lead is due to a test due to hydranencephaly. This baby has what we call hydranencephaly. Trans-illumination refers to a test in which a bright light is shined through an organ or cavity to detect abnormal presence of air, as in pneumothorax, or fluid, as in hydrocele, and in this condition, or in its differential diagnosis. In hydrocele, by the way, it is a good negative test, but if it is positive, it doesn't rule out other problems like torsion of the testicles. You should do ultrasound. But it's helpful as a screening test. In this figure, the hydranencephaly gives a positive test. This is the arrow, which see all this trans-illumination of most of the cavity in the skull, both sides. You don't see a lot of expected brain tissue. But this is very crude. The MRI is the best, but parents refused. Genetics, important, but the parents refused. So what is the actual diagnosis? With large fontanelles, positive trans-illumination, he underwent MRI and proved to be hydranencephaly. And we have these typical findings in the MRI. So my MRI, bilateral, frontoparietal, A and B, frontoparietal, and lateral temporal in the C and D, replaced by fluid, and without any remnant parenchyma with sparing of bilateral occipital lobes. This baby has no brain or no hemispheres, but the occipital lobes, and that's it. Otherwise, no brain tissue, and it's all filled with CSF. It's very, very bad prognosis, very bad disease. The prognosis is very bad. Okay. Table 2 summarizes the key findings of MRI. Table 2. Table 2, if you do ultrasound on the day one of life, you will find absent bilateral frontal, parietal, and temporal lobes. There is different degrees. And remnant posterior, parietal, and occipital lobes. Neither the lateral nor the third ventricles were visible. Flax cerebri was seen with normal posterior fossa structures. There were no area of intraparenchymal or intraventricular hemorrhage. This is important because if we think of hydrocephalus or hydrocephaly or some insult in utero that could lead to any of these developmental and malformation issues, it could start with a blood clot. It could start as a blood clot secondary to hemorrhage, or it could start like a stroke that destroys the developing brain. If you do MRI, you find absence of bilateral frontal, parietal, and lateral temporal cortices, which are replaced by fluid. The medial, temporal, and occipital lobes were normal. There was some remnants, occipital lobes. Bilateral thalami were unfused with a normal third ventricle and cerebral aqueduct. Falx was present, and the bilateral. This is all anatomical structures. You should be an MRI expert to discuss all this. I don't believe we can do that. Even the ultrasound, which I know you do it very much, I don't think you will be able to discuss all these anatomical issues. CMV is negative, toxoplasma negative, karyotype is 46XY, hearing is normal, eye exam was normal. So, okay, hydranencephaly is an uncommon congenital brain malformation. It causes cerebral hemispheres to be absent and replaced by membranous sac-like structure filled with CSF with the preservation of basal ganglia. That's why with this baby and brainstem and other structures, why this baby was doing very well at birth. This baby did not have any respiratory distress at all. Apgars were 8 and 8, but actually has no brain. Key stages of fetal brain development include, yes, important issue is that neurulation, neurogenesis, neuronal migration and differentiation, synaptogenesis, synaptic pruning, and myelin sheaths. These all different stages of development of the brain. It has very sophisticated terminology, but I will make your life easy. This is the development of the brain in utero. Like all other organs, most of them start to develop by the gestational age of 4 weeks. And this is the brain. It starts like the end of a closed tube, and then starts by organogenesis or development. It starts to become more and more visualized and more divided. And this is at 4 weeks still. 4 weeks and 4 days. Yeah. We see at 4 weeks and 4 days the neural folds within the brain folds within the brain, this is the neural folds inside the brain. Fused neural folds here to close the brain. And we keep going and with different stages of development, including the terminology I mentioned before. And this is at the age of 5 weeks and 2 days. And the tube starts to develop and to differentiate the brain tube into forebrain, midbrain, hindbrain. Metencephalo, mesencephalo, whatever, cephalon, diencephalon. This is fore, mid, and hind brain. More differentiation. And then this is at birth. This is the full term brain. And there is another stage which does not show here, which is extremely important, which is the migration of the neurons. The brain does not only develop as seen by these pictures, but inside the brain, the neurons of the cortex start initially in the periventricular region and then start to migrate towards the cortex. That's why there is, among the malformations of the brain, there is migration disorders, disorders of migration of the neurons. Okay, this is and this is how the CSF is formed. Okay, we have different pathological abnormalities of the brain, including neural tube formation, neural tube defects, prosencephalic development, neuroblast proliferation and migration, cortical organization and myelination. Okay, there should be an underlying genetic disorder. So we have anomalies of the cortex development, hydranencephaly, and we talked about hydranencephaly, and it has no treatment, and the prognosis is horrible. This baby will develop macrocephaly at some point because, as we mentioned, the head was relatively high. The head circumference was relatively high compared to the size of the baby. This is the how we can see in the ultrasound the hydranencephaly. And then holoprosencephaly is failure of appropriate cleavage of the prosencephalon into deep structures and hemispheres of the brain. So the brain, instead of being two separate but connected two hemispheres, it turns to be there is failure and there is types. Okay, there is a spectrum of severity, and it could be alobar, lobar, or semi-lobar, and the lobar is the worst, and then the semi-lobar is intermediate, and then the alobar is the best. It could be associated with hydrocephalus, pituitary dysfunction, because it affects midline structures. Yes, this is the A-lobar, complete fusion. This is the worst. Lobar, some degree of division that goes as far as maybe the posterior part of the brain, and this is the segmental in between. And this is the A-lobar and lobar holoprosencephaly. This is lobar A, and B is the A lobar. And this is the MRI. This is lobar, A lobar, semi-lobar. The schizencephaly is a neuronal migration defect in which one or more of the fluid-filled clefts, it's a cleft. Schism means cleft in the cerebral hemispheres, communicable or communicate with the lateral ventricle. Communicate with the lateral ventricle. This is the lateral ventricle, and this is the schizencephaly. This is the cleft. This is the cleft communicating with the lateral ventricle. That's why it's CSF filled. It can be unilateral, can be bilateral, can be associated with microcephaly and other brain anomalies. There are types, type 1, type 2. I will send all these details to you when I'm done with all these MCQs. Agenesis of the corpus callosum is important. Normally, there is a connection between the right and left hemispheres. And this is how your brain communicates. The right side knows what does the left side do, and the left side knows what the right side does, and they are communicating. If there is no corpus callosum, there is no communication, and the right side does not know anything about the left and the other way around. It's very weird. It is the major pathway that connects the left and right cerebral hemispheres. And it starts to develop by the age of 13 to 14 weeks. And there are different degrees. Agenesis, no corpus callosum at all. Hypoplasia, small size, and dysgenesis, present but malformed. A lot of details. Disorders of neuronal and glial proliferation, neuronal migration and specification, midline patterning, axonal growth, and it's a lot of chromosomal anomalies. And it could be isolated. If it's chromosomal, it's syndromic also. There is a very good site for genetic disorders. If you have a baby with multiple anomalies, and you think, oh, we don't know what syndrome is this, you go to a site called OMIM, O-M-I-M. It's free site. And this OMIM, you give the clinical presentation of your baby, what is wrong with your baby, and the site will give you the diagnosis. What syndrome is this? OMIM, O-M-I-M. Also could be associated with other anomalies, and this is a development, this is normal corpus callosum, and these are the structures, details of neurology and neuroanatomy, and this is the absence of the corpus callosum in B. There is no corpus callosum. There is no corpus callosum. You see? And there comes ventriculomegaly and hydrocephalus or hydrocephaly. Hydrocephalus. Also enlargement of the ventricular size, which can lead to hydrocephalus, and you have to rule out tortious infection or chromosomal anomalies. We can talk about head size abnormalities, microcephaly and hydrocephalus in a separate presentation. And I believe this is a good article to present. Also, if someone wants to go into the details of the malformation of the brain in details, it could be a good article. And this is mild ventriculomegaly, which may or may not resolve at the end of pregnancy, but it needs follow-up. And of course, there is certain diameters and measurements by fetal ultrasound can let you know if there is ventriculomegaly or hydrocephalus or not in the fetus. And the most common cause of hydrocephalus, of course, is aqueductal stenosis, and this causes bilateral hydrocephalus. For encephalic cyst, also important. Fluid-filled cavity in the cerebral hemisphere. It could be anywhere, infratentorial or supratentorial. It could be one or more than one cyst. And the third trimester, these cysts are thought to result from ischemic parenchymal vascular damage. That's why we mentioned initially this baby didn't have evidence of intracranial hemorrhage or parenchymal lesion, which could, if this happens early in utero, depends on the site, there will be vascular damage followed by necrosis and subsequent liquefaction of the brain. Yes, this is the porencephalic cyst, which is connected to the ventricular system. And then another term which you come across, not related to this baby, not in the differential diagnosis of this baby, it's lysencephaly. Lysencephaly means the brain is smooth. Smooth brain means there is no gyri, means there is no cells because there is failure of neuronal migration. And this, so this, the cortex, it is a cortex with no or minimal or a small amount of neurons. That's why the brain is smooth, called lysencephaly. This could be associated with microcephaly, ventriculomegaly, white sylvian fissures, complete or partial agenesis of corpus callosum. These abnormalities could be isolated or in combination. You could find more than one abnormality of the brain. Two types, as usually they like differentiation and classification. Two types of lysencephaly, never mind about that. Of course, this baby has problem with the brain. You don't see a lot of gyri. Syndromes with structural malformation of the brain. We said every and each abnormality could be sporadic or syndromic. So we give you some of the syndromes that because we are running out of time, I will not go into the details of any of these, just I mention names. The corpus callosum agenesis or hypogenesis could be associated with Aicardi syndrome or other syndromes. Type 1 lysencephaly, Miller-Dieker syndrome, isolated. You see, all these are genetics. Type 2 lysencephaly, some other syndrome like Walker-Warburg syndrome. Polymicrogyria, cortical dysplasia, other syndromes. Okay. Schizencephaly, monosyndromic schizencephaly. Megalencephaly. I believe that the genetics is the future science, and it is definitely today's science, and it is the future science. And you can diagnose every and each disease just with going to the genetics. But you have to tell them what you are looking for, or at least what is abnormal, and they think with you, because they can do tons of labs, which are tens of millions of dollars worth. Megalencephaly, other syndromes, microcephaly, holoprosencephaly, Pateau syndrome, which is trisomy, septo-optic dysplasia or de Morsier syndrome, septo-optic dysplasia, and others. Okay. Lessons. Important clues for the determination of the underlying etiology of severe fetal brain ventricular dilation include associated brain malformations. In intactness of the brainstem structures, cortical mantle, and coexisting facial malformation or systemic, because it could be syndromic, systemic manifestations. Bedside transillumination is a good test, serves as a valuable supplementary tool if you don't have the luxury of doing MRI or it will take time. Okay? And I'm going to stop at this point. We are almost 2 hours now, which is too much. Any questions, any comments? Okay, we are going, inshallah, to meet on January 2026 at same time on 28th of January, inshallah. Okay?
إن شاء الله يا دكتور، شكرا جزيلا لحضرتك، شكرا.
ونشوفكم على خير إن شاء الله. مع السلامة.
شكرا يا دكتور، شكرا.
مع السلامة. What is different? What is the difference between cystic PVL and porencephalic cyst? Cystic PVL can turn into a porencephalic cyst, but this is outside the spectrum of our talks today. PVL, periventricular leukomalacia, it's something acquired. It may be due to intrauterine insult. And if it is cystic, if it is large enough, it could cause porencephalic cyst. Yes, but this is not our talk today. Okay? Thank you very much. Assalamu alaikum.